So very good afternoon, and I'll be talking on tackling small people in cataract surgery. I have no financial interest. So already a lot of discussion has been going on. So non-dilating people is a significant challenge even to a very expert surgeon. And we know a lot of causes like PXF or a traumatic cataract or uveitic cataract which we get. And capsular excess is one of the difficult things which if you have a small pupil, and PCR or a capsular tear is very common. So let's look at the first pearl of mine. When we are intraoperatively looking at these cases, so first and foremost, you have to do two things. You assess the pupil, whether you are dealing with a rigid or a elastic pupil. So why it is important to distinguish between these two? Because if you are dealing actually with the IFS and you stretch it, then you make the pupil more floppy. That is important thing. And if you are dealing with a rigid pupil, then you have to have a stretching to be done, and then only you can go in. So if you are dealing actually with the elastic pupil, go ahead and it's like a rubber band what he was talking to you, and any expander will work. So looking at this case, you see this is a pupil, and then I'm putting viscoelastics into it. It dilates. So you can understand now what type of pupil we are dealing with. So if you are having a rigid pupil, as they have discussed already, you have to do a stretching in those cases. You can use two Sinskis or a Kugler's hooks in these cases. If you are dealing with a uveitic cataract, you will see the membranes, you have to do the membrane peeling. And when you are doing a sphincterotomy, do multiple sphincterotomy. Be very careful, don't go beyond the collarettes, otherwise you will have glare afterwards. About the pupil expansers and the iris hooks, already dealt with it. So both of them are good, and it depends on your hand, but this rings give you a uniform dilatation. So next point, which is important, what is the critical diameter of the pupil to be considered as small? So for an expert surgeon, even he can go about doing with 5 millimeter, but 6 millimeter, less than that, even for an in-between surgeon, it's difficult to go on. So I'm not discussing about the pharmacological, it's already dealt with. And BX expanders, these are some of the expanders which he was talking to about. And Malignance ring is something which most of them have used. And this is a oral lab of Innova, which has come out. And this is how your pupil size looks with different type of iris hooks or expanders you are giving. And once this is achieved, your phaco is fine. So let's go about one of these cases. This was a 68-year-old gentleman who was in Florex, and he had come. So from the beginning, we know that this is a floppy iris. We were prepared in this sense that we started. This is a Gupta ring which I am putting. So be careful when you are inserting this. You don't stretch much of the pupil, because what we want is a dilatation enough to go about with it. Once this is done, you have enough good thing. You can go about with a rexis of 5 or 5.5. And after this, be careful whatever you will be doing. The rest of the things will become simpler. So we are doing hydrodissection, and then you do a good rotation once you are having. And then your nucleus, you go in with a chop, or you can do with a stop and chop. Here I was doing a stop and chop, and actually doing a multiple small fragmentation of the nucleus. And it was not a very hard, so you could go about with it. And this is how the multiple fragmentation in this case was there. And so each pieces were taken out, and then you do a good cortical wash, and you can put an intraocular lens, and then you remove Gupta ring. This is how. So this is a mechanical thing which you will be doing, and you will be removing it. The next case, this is a nice case, a lady who had come to us, and you look at, this is a PDR case to us with a PI already done. So I thought I can be very good and go about it, but you see the constriction which is happening. So I have to do I had already done a rexis, and I put in the ring, and then only I could complete the case. So this is my last, where I'll just show you. So this is a very small pupil, and this patient was initially done So there was no rings at that time with me, so we can go and do the hooks. So when you are learning also, when we are teaching our PGs also, with the hooks we start. So as discussed previously, so we did a 4 stab incision and the hooks were kept. And once you have this, there is nothing much more into it what I'll be talking to you. And you have a good enough, you do a good rexis, and then you do your nuclear management. Why I'm showing you is this: the patient actually wanted a multifocal in this, and we have to be careful enough. And this is, okay. So I'll just complete. So, okay. So my take-home message is, as previous talks have been given, you have to identify the risk factors. You have to have all your armamentarium during surgery. Be careful to know whether you are dealing with a rigid or elastic pupil. You keep your iris hooks expander with you, and post-operative regimen also has to be taken care, because some of the cases you will have glare and all, and then some of the cases the post-operative eye drops has to be taken care of. Thank you.
Thank you, madam. Thank